Okay. So low-grade glioma. So what is low-grade? So last case presentation we discussed about uh, we did discussed about subependymal giant cell astrocytomas and pilocytic astrocytoma. Those are classically grade 1. Pleomorphic xanthoastrocytoma, pylomixed astrocytoma, diffuse astrocytomas are grade 2 tumors. Oligodendrogliomas are also grade 2 tumors. So now, what you must understand here is that when you talk in adults, 85 to 90% of the time, the data suggests that we would getting low grade, we would be getting as grade 2. The TMH data suggests that it will be actually 92 to 93% that you will be getting adult low grade will be grade 2. It's very rare to get an adult grade 1 tumor. You must suspect an adult grade 1 tumor when, especially if it is attached to, associated with, not attached to, is associated with some neural syndromes like NF1 or tuberous sclerosis, then you may think about it, but it's rare to get it. So how do you say that this is grade 2 and not grade 3 or not grade 4? So grade 4 means, we'll go from below up. Grade 4 means there is going to be necrosis, there is microvascular proliferation, and there is high rate of mitosis. In a grade 3, there is no necrosis, no vascular proliferation. There will be only infiltrated tumor with a high mitotic rate. In a grade 2, it will be no necrosis, no vascular proliferation, low mitotic activity, and it's kind of a homogeneous tumor. Understand, like the BST, like bone and soft tissue, the grading and the diagnosis of in gliomas is a clinico-radiological, no, patho-radiological. So you look at pathology also, you look also at the radiological picture. The issue happens is sampling errors do happen. You may not be able to remove the whole tumor. So radiologically, whatever information you get gets added up. For example, if you see enhancement in a T1 contrast, then which means that there is macrovascular proliferation and there's like glioblastoma. There are certain situations like oligodendrogliomas and pilocytic astrocytoma can also have vascular enhancements, but these are this for at your level. It's remember, if it's enhancing is there, it is a high grade tumor. For example, if the necrosis is seen, then it's a glioblastoma. So these things need to be kept in mind when you look at the radiology and the pathology. Now, grade 2 tumors, mostly patients will be young adults. And one of the characteristics of grade 2, as you can see, is IDH1 or 2 mutations. It's important to look at IDH1 or 2 mutations. So it's, for example, if a patient has a grade 2 like pathology, but molecularly it is IDH1 and 2 negative, checked it both by IHC and both by sequencing, the behavior of this patient will be more like a glioblastoma, more similar to a glioblastoma than a low-grade glioma. And it's important that hence you molecularly also confirm that it is an IDH mutated tumor. Now, when you look at IDH mutated tumor, and if there is presence of TERT promoter mutations, which is here, these are most of the time accompanied with 1p19q loss, and these are either grade 2 or grade 3 oligodendrogliomas. So IDH1, and then you get a TERT mutations, and then this follows the pathway to become an oligodendroglioma. If IDH1 and ATRX is lost, so remember ATRX and 1p19q both are never lost together. So if ATRX is retained, then 1pq19q loss would be there. If ATRX is lost, it's very unlikely that you will get 1p19q loss. Then this becomes a grade 2 astrocytoma. Today, we will be focusing only on this part. In grade 2 astrocytoma, additional mutations lead to development of grade 3 astrocytomas. Additional mutations lead to a development of secondary glioblastomas. So astrocytoma can go to glioblastoma. Remember, if it's an oligodendroglioma, you don't see here a glioblastoma component. So even in a oligodendroglioma, if it's a grade 3, you see a vascular enhancement or a necrosis. The pattern of behavior still is like a grade 3 only. So there is no At present, the WHO does not classify oligodendroglioma origin tumor as having grade 4. The maximum grade you can achieve is grade 3. And we won't go in this details. So how do you apply this in a clinical practice? You get a patient from a neurosurgeon and he has got operated and you have the histology with you. You do IDH. If it's IDH mutant, then it's likely that it's going to be a grade 2. It's likely to be a low grade glioma. And you look at the ATRX loss and 1p19q correlation, that will tell you whether it's astrocytoma or it's an oligodendroglioma. And this is the way you write the whole diagnosis. The diffuse astrocytoma IDH1 mutant, it's oligodendroglioma, which is IDH1 mutant and 1p19q correlated. So that's the perfect way of writing the diagnosis of this patients. Now, the question comes, how does this patient present? Now, low-grade glioma, the presentation is mainly by seizures. Seizures is the commonest thing which you see. And when you see a patient with seizures, the likelihood that the thing would be an oligodendroglioma is high. Cortical thickness is seen in low-grade gliomas. Most of the other things are pretty non-specific. Actually, seizure also is non-specific. So as we discussed in the last class, what we must do is, if you have a patient who is a young adult, does not have a history of seizures and gets sudden seizures, please get an MRI done to rule out any pathology in the brain. What are the imaging features for low-grade gliomas? You would see most of them are lobar. As we discussed in the last class, also deep locations or midline locations are unlikely to be low-grade gliomas. Most of the times they are single. Very unlikely you would get multifocal low-grade gliomas, but you can get that, especially if they're associated with some syndromes. The most common site where you would get is frontal and temporal, and this dictate the behavior, the changes kind of you see. Like with frontal, you would have seizures and personality changes. Temporal, you would also have, you can again get seizures, and with you may have behavioral changes which are seen in this patients. Enhancement, though this is from an old EORTC study. Nowadays, if you see an enhancement, it should be classified as a low-grade glioma. In certain types, in oligodendroglioma can though show enhancement along its capsule. Size greater than 5 centimeters is commonly seen. Understand it's a slow-growing tumor, so it takes time. So whenever you take history of the patients, you will find that things like personality changes, getting angry, showing tantrums will be there for quite a bit of time. So it's not easy for the family also, or even for the person to realize, because the changes are not sudden. The changes have taken over a period of time to tell you, okay, no, this is not this is a change which we have observed. Does it cause calcification? Yeah, in 10% it is associated with calcification, best seen in a non-contrast T1 or a CT scan, and this feature is associated with oligodendroglioma. Now, can you tell on the basis of imaging whether the patient is likely to be IDH1 mutant or not mutant? Yeah, there is what is called as a T2 flare mismatch. So I'll explain you what this is. So you see this T2 image here. You would see wherever there is heterogeneity, and wherever there is heterogeneity, you could see that these areas are dark also on the flare imaging. Now let's look at this imaging. This area is dark, but that same area in flare is light. This area which is light, that area in flare is dark. So this is called T2 flare mismatch. And if you see this T2 flare mismatch, there's a high likelihood that this tumor is likely to be an IDH mutated tumor. Now, this is not a very confirmative thing, so don't be a great radiologist. Always get a molecular analysis done. The second thing is the mismatch should be over 70% of the area to tell you that this is that exists a mismatch. So what about the prognosis of this grade 2 gliomas? Understand that when we look at this tumor, even if you say that they do well, with respect to that, what happens in a control population. So the curve here, the blue curve is actually for an age match general population. You could see that astrocytoma, though overall we say it's a good tumor, it does do quite poorly with respect to patients of the same age who don't have an astrocytoma, whichever type it is. In fact, you would be surprised that even pilocytic astrocytoma with respect to control population doesn't have the same kind of survival. So understand, though it's said to be a low-grade glioma, don't be very heroic with it. Saying, no, nothing happens, we can keep an observation. No, the patient needs to be, you need to look at the risk factors. You need to take a multidisciplinary decision, what will be the in the best interest of the patient. And how do you take these decisions? This is two old studies done by URTC, 22844 and 22845. And what they got was, these were the negative factors they identified from these phase 3 studies. Age greater than 40, if there's an astrocytoma histology, if the tumor is 6 centimeter or it's crossing midline, the presence of neurological deficit before surgery. Uh, Actually, there are only 3 factors here. One is actually age. Second is the histopathology. And the third is that the surgery cannot remove the tumor completely. Why they can't remove it? Either its size is more, or the tumor is crossing the midline. It's very difficult to remove the tumors which are crossing midline, or there is already presence of neurological deficit before surgery. So you are worried if you try to do extensive surgery, the patient may land up with more deficits. What we've seen is presence of any of these 2 factors, any of this less 2 factors or less, your average median survival is 7.7 years. If you're 3 or more, you are in the higher risk group according to the URTC. Now there is a recursion partitioning index which has been made for this situation. We won't go in that. So let's say that if you see a patient who has an SOL and it looks like a glioma, it's homogeneous. It has that T2 flare mismatch, likely to be IDH1 mutated. No enhancement, no negative. What's the first thing you will do? The first thing you will do is refer him to a neurosurgeon and get a maximum safe resection done. Now, understand that when we say as opposed to other cancers, where you always like to have an R0 resection, you want to remove the whole tumor there, we have to balance out the risk and benefits of doing that in CNS. Neurological deficits are there when you do such things. So what you do is, in such situation, you remove the tumor as much as it's possible. If all gross tumor can be removed, it's called total resection. If greater than 90%, but it's not 100% has been removed, it's called near total. Subtotal is 50 to 90%. And if less than 50% is removed, it's called a biopsy. Now, what we see is that maximum possible resection needs to be done. So you would get sometimes references where a biopsy has been done and the patient has been referred to you. So say, okay, do we need to do a completion surgery? Yes or no? Yes, you need to do a completion surgery. This is a outcome data, and what it shows is that if you're a cross-total resection as opposed to a subtotal resection, it has a survival benefit and a progression-free survival benefit. What about if the patient has done only biopsy and he comes to you and decides, okay, a biopsy has been done, the surgeon feels that it cannot be completely removed, should I remove it or not? So you should consult your MDT and talk with your neurosurgeon that whether he can remove 50% or more. If he can remove 50% or more, that is subtotal resection. Subtotal resection as opposed to biopsy has shown to be of benefit. Let's say that someone has only 10% of the tumors and someone feels he can put it up to 70% of the tumor can remove. Definitely you must go for this resection. Things become complex if someone has instead of 40% tumor and you feel that another 10% or 20% can be done, then it's a gray zone area where you would say that probably in this situation you may not go for a resection. So in most of the situations, well, if you are looking at non-volumetric analysis, there were some situations that whether there's benefit or not benefit of doing a complete surgery. But when you look at volumetric studies, 3D volumes, there is all the data suggests that doing good surgery in low-grade glioma benefits. There's another thought behind this. People say that those low-grade gliomas who are better are well or can easily be removed, as opposed to those low-grade glioma which are not that better, more infiltrating, and the removal becomes difficult. So, what is the what are the unanswered questions with respect to neurosurgical gain? So one is thing is something called as doing a supramarginal resections. What we mean by supramarginal resection is nowadays the concept is that it is not an eloquent cortex, and if you could remove the whole uh, lump along with the tumor, maybe it may do better. And there is a concept that in IDH1 mutated patients, this kinds of resections might benefit. The suggestion to that, we don't have concrete data. In GBM, we use a lot of navigator help, like ultrasound, MRI, giving aminolavinoic acids. These adjuvants do help with in the low-grade glioma also to do completion of surgery. However, the data gets extrapolated from GBM, but these things are important. Okay, patient gets a neurosurgery done, comes to you. The question is whether he would need radiation or not, and radiation or not. So the first question is a low-grade glioma, a grade 2 specifically, has come to you, whether you would put the patient for radiation or whether you won't put the patient for radiation. Let's answer this into two with this respect to this EORTC study. The study was published in Lancet in 2005, and for long-term results of low-grade astrocytoma patients, who, if you see here, were mainly astro-oligo and incompletely resected pilocytic were taken, and they were randomized to receive radiation or receive radiation when they progressed. In the patients who received early radiation, the PFS was 5.3 years, as opposed to 3.4 years in the patients who did not receive radiation. However, the overall survival was seen. The only benefit which was seen was till 1 year, not after 1 year. The seizure frequency was better controlled in patients who received early radiotherapy. Now, the question here is, there are two ways you can look at this data. One is you keep the patient on observation, and if you could administer radiotherapy when the patient progresses, it's okay. Patient does not lose their life. Okay. Unfortunately, the study never looked at quality of life. They only looked at seizure frequency. So we can't make any comments about what is the quality of life of this patients. But it also shows that the seizure frequency becomes similar after 1 year, and observation can be a strategy if your patient is a good follow-up candidate and who is ready for good monitoring. Now, whenever you do observation also, you need to have certain things into place. It's better to observe for a cross totally resected tumor with an oligodendroglioma histology. If it is not cross totally resected or with an astrocytoma histology, the chances of that they are going to fail are still high. Now, how do you assess risk factors? And this is the RTOG classification. And I try to remember this only because it's very simple. Looks at only two things: age and whether there was a gross total resection or not. If the age is less than 40 and it's a gross total resection, they say you can observe the patient. If the age is greater than 40 or there is a subtotal resection, then in that we have this study, we would say high risk, whether we would be radiation alone or radiation followed by PCV. So this is what I was speaking to. In the RTOG study, what they saw was patients who had astrocytoma histology, or in the low risk population, which was kept on observation, astrocytoma histology, a residual tumor if was present, or the preoperative tumor diameter was 4 centimeters. The outcomes were bad in this. Like the 2-year PFS was only 60%, and the 5-year PFS was only around 12%. So why is this important? This is important because, as I told you, if you're going to select a patient for observation, it better be one which has cross tumor resection has been done. There is no residual tumor, and it's not an astrocytoma histology. Because if you don't have this three, then the 2-year PFS rate is 100%, and the 5-year PFS rate is 70%. So that is the way I would take a decision in clinic. Like, okay, the patient age is less than 40, he has complete resections, whether astrocytoma histology is there or not there. So now what, okay, you would say that, okay, uh, I would classify the low risk into another group, whether there is astrocytoma histology or not. So if you decide to give radiation, what dose you should give? So there are two trials in this, one from the EORTC which compared 45 Gray to 59.4, and it didn't show any difference in outcomes. Another trial of 50.4 versus 64.8, again it did not show outcomes. So when you take these two trials together, a moderate dose of 45 to 54 Gray using localized fields, which means where the tumor was with a 2 centimeter margin, is enough for you to give radiation. Conventional radiation, doing hypofractionated radiotherapy or hypofractionated radiotherapy, use of radiosensitizers, have not shown any benefit in this subset. So up till now, what we have discussed is patient undergoes surgery. After surgery, you would classify if the patient at low risk or high risk. And coming to the high risk, you would definitely give RT and chemotherapy. We'll be discussing about chemotherapy in details now. If it's a low risk and you're using the RTOG classification where age is less than 40 and there is complete resection done, which means there is no residual, I guess, you will look at the histopathology. If the histopathology is oligodendroglioma, still this is a candidate for observation. And the histopathology is non-oligodendroglioma like astrocytoma, you would prefer to do radiation. Now let's see how we can fit chemotherapy in this paradigm. And these are the results of temozolomide in low-grade gliomas. And we could see that the response rate with temozolomide is variably been reported across other studies, that it can range from 10% to 60%. And the 1 year survival can be anywhere between 40% to 93%. So RTOG, EORTC, the next study in low-grade glioma actually asked this question, whether giving temozolomide would be better than giving radiotherapy or not. And they, in this time, they were smart. They not only looked at outcomes, they looked at quality of life, and they also looked at neurocognitive, neurocognitive. Now, one of the things which you must understand is when these assumptions were made, they said that, okay, temozolomide, they didn't go for an inferiority, non-inferiority study. They said that temozolomide would be better than RT. Now, frankly, if the quality of life remains the same and the deterioration is not that, even if the temozolomide is non-inferior, if it is a non-inferior design, most of the people would have accepted the way it is. And in this study, if you could see, this study was a negative study because they wanted to show that temozolomide is better than RT. But overall, if you could see that the study did show that there's no much statistically significant difference whether you use only temozolomide or you use radiotherapy. And if you look across most of the situations, especially when you look across this situations where if you look at this was a mixed bag. You could see that total removal of the tumor was done only in 12% of the patients. So most of these patients will have biopsy or partial removal. So actually in today's world, according to RTOG, this would have got classified as most of this is high risk disease. So this is not a study actually in so-called RTOG low risk group. It's more of a study. You could see that more than 40 age were nearly is majority of the patients. So it was a more of a study in the group which is a high risk, trying to see with the temozolomide versus RT. And what you could see here is that when you look at the after you start, there was not much difference in quality of life between temozolomide and radiotherapy, except at 3 months, the quality of life with temozolomide was better than radiotherapy. And you could see this differences. MMSE scores were similar. The changes from baseline were statistically 3 months, but they met at the end of 36 months. So what can you conclude from this situation? See, this study is a study which is kind of a misfit. When you're looking at actually the high-risk glioma and try to say with the RT or temozolomide, the study next, which I'm going to show you, that is RTG 9802, made it very clear that in a high-risk glioma, you have to give both RT and temozolomide. If you look at the data from the perspective of low-grade glioma, it seems that it is reasonably okay to replace temozolomide with RT in a low-risk glioma who is a candidate for, um, like for example, if I have to put it again, patient has undergone surgery, age is less than 40, and there is gross total resection done, and the histopathology comes out to be astrocytoma. Now, in my mind, this patient has a high risk of recurrence. Then I would want to give RT. And if the patient does not want RT, it's perfectly okay to give temozolomide. In fact, it's perfectly okay for you to explain both the options of whether you want to give temozolomide or RT in this situation. Now we come down to the RT plus chemotherapy, and then we come down to this. So this is the group we have discussed completely. Low risk, age greater than 40, cross total resection has been done. If it's an astrocytoma histology, you would say RT or temozolomide. If it's a non-astrocytoma histology, you have the option of observation. But if you feel that the patient is not a good follow-up candidate, RT or temozolomide can be given even in this situation. Now we will discuss about this where there is ages greater than 40 and there is a residual tumor which has been seen. And what we see is this: in this study, one arm got radiation, another arm got radiation followed by PCV. And there was no doubt that the radiation followed by PCV had huge impact. You could see that the progression-free survival jump at 10 years from 25% to nearly 60%. A hazard ratio is 0.5, and this was seen all across all groups and more so in IDH mutated patients. The benefit was huge of adding PCV. You could see that the benefit is around nearly around 40 to 45% at the end of 10 years. So there is no doubt that the PFS improves. Let's see whether the corresponding overall survival improved. Yes, the good jump. You could see that this is around 30-35%, and this is around 60%. There is a good jump of 20 to 25% improvement in survival with the addition of PCV. And this is more so when you look at the patients with oligodendroglioma. Normally, the people start saying that if it's oligodendroglioma, they do better. Maybe we may not have to be that aggressive, but as opposed to that, in oligodendroglioma, the benefit was more than what was seen in astrocytoma. In IDH mutated patient, again, the benefit was huge. So when you look at this, if you look at the hazard ratios, they are 0.4, 0.5, which means it reduces the risk of your mortality or progression, brings it down to half. So there's no doubt that you need to offer chemotherapy in these patients. Problem, PCV administration is a skill issue. You need to be trained. You need to have seen these patients because this is a tough schedule to deliver. That the schedule one cycle is over 2 months, in which 1 month, the second month is actually has no chemotherapy, but the first month has extensive phases of procarbazine intermingled with CCNU and BCR, and it does lead to side effects, neutropenia of around 55% grade 3 or more, platelet count disruption. If you see in the protocol setting, even in RTOG trials, the median numbers of chemotherapy, which were 6 were planned, were received with 3 for procarbazine, 4 for CCNU, and 4 for vincristine, and only 56% could complete the chemotherapy. So, a difficult schedule to give, but even if it's a difficult schedule, even with this, I could incomplete administration, the benefit is so huge that you need to take that risk. Now, as is a habit, if there is a complicated schedule, one of the schedules, especially for gliomas, which was again seen by RTOG, was in RTOG 4024, a single arm study in which RT temozolomide followed by was replaced with temozolomide. We have 3-year overall survival of 73% in this risk group. Now, the issue here is whether the 3-year-old survival is good enough to take your discuss this, whether it can be replaced. I'm not very sure we should be taken as replaced. You could see here that in this study, the problem was RTOG, this was the second or the third report of RTOG. The initial reports all talked about was initially it looked like negative. The second report showed that there was a PFS benefit. The third report which showed that there was an OS benefit. As you can see, the curves only start diverging after 4 years. And the divergence continues till 12 years of follow-up which we have. And so Actually, in IDH mutation divergence, again, you could see starts only after 4 years. So, data of overall survival of 3 years or 4 years is inadequate to make this conclusion. Even if you look at data of PFS, the curve starts diverging only after 2.5 years. What does this mean? This means that you need long-term follow-up to make any conclusions in this kind of biology of tumor. And there have been debates in favor of PCV, debates in favor of temozolomide, everyone making their cases. And this is one of the hotly debated topic at every neuro conference, whether what you want to do. When uh, people don't change their mind, actually, they do what they like to do. If you ask me what you should do, you should give PCV in these patients because the data is overwhelmingly in favor of PCV. This is a regimen which has shown a survival benefit, and so replacing it with another regimen with inadequate data may not be the correct thing to do. Now, if you look at integration of molecular subgroups, I made a comment that IDH wild type is not to be taken as even if the histology supports. Then you could see here those who are IDH mutated, how well they do with RT-PCR, how well they do with even if the correlation is there of 1p19q or not there. So obviously the best is by IDH mutated tumor and presence of 1p19q correlation. We could see that the 10-year survival in these patients with RT plus PCV is at the tune of 90% nearly. With respect to the PFS, with respect to 10-year PFS is around 65%. But if you look at this, where this negative, this is more or less like the way you would see the curves for glioblastoma multiforme, and this is for overall survival. But I can see the 10-year survival is around 90% if this IDH mutated and it's correlation positive. The overall survival at 10 years is around 65 to 70%. So that's just what I'm telling. There's a huge benefit which is seen with this drug. So do we have some data from TMH? So because this is a good question, whether in low-grade gliomas what to be give, we have a randomized study running at a center, RT followed by PCV or RT temozolomide followed by temozolomide. We have recruited quite a few patients in the study up till now. And what I'm showing you is the results of initial 50 patients, and Dr. Nandini will be presenting this at the neuro-oncology conference, presented this at the SNO conference in 2021. If we could see that nearly half of our patients are greater than 40 years of age, and that's make if the GTR, we get a substantial number of patients in which there is subtotal resection or a near total resections. Our oligodendrogliomas are 50% and astrocytomas are 50%, and 94% of the patients are IDH mutated, 5% are IDH wild type. Now, I can't show you because the study is only of 3 to 4 years duration, the outcome data. What I can show you is the compliance data, which would be of more interest to most of you. And if you look at this per protocol analysis for completion of adjuvant chemotherapy, this was 56% for receiving RTOG. We have its rates of around 71%. The reason why I've said per protocol is because two patients here actually didn't start, one because of COVID lockdown and one patient of default. And if you see what are the reasons for not coming, our main reason was toxicity. COVID-related deaths and defaults were one of the reasons in PCV. Our median number of cycles was 6 as opposed to 4 and 3 for RTOG. We had a lot of dose delays and dose reductions, but that was mainly because of myelosuppression and bronchitis and neuropathy, which is seen with this here. If you see how many patients completed all and cycles, 71% when we go for per protocol analysis. And so what I'm trying to suggest to you is that yes, it's which is a high volume center. Most of your patients will complete your PCV regimens. What are the kind of side effects which you see with PCV? Mainly myelosuppression, lymphopenia, raised LFTs, and neuropathies. You would also get kind of one of febrile neutropenias, which is seen seen in this study. Does the giving the this is the gist of the scores. So this below ones are for the PCV and the blue ones are for chemo. The quality of life scores over the time, and you would see that not much difference in the quality of life scores if you see with respect to both the arms, and this is the attainment for that. The relative hazard of declement in any of this quality of life index is nearly 1. So over the period of time. So even though there is, it seems that PCV requires frequent visits, there are side effects, but quality of terms it is not impacting our patients. The same things with BN20, you should see it doesn't impact the patients. So looking at all these things, what would I say? So if you have a low-grade glioma, use RTOG classification, age less than 40, complete resection of the tumor, which has been checked by you in a post-operative MRI, not what your neurosurgeon is saying. In that case, look at the histopathology. If the histopathology is astrocytoma, you have the option of giving RT or giving temozolomide. I would keep observation as last option because the 5-year chances that the patient would fail is nearly 90% in this situation. If the patient has oligodendroglioma, the options are in that situation, I would first put as observation, or if you think he is a not good candidate for observation, temozolomide or RT. If the patient has a high risk factor, which is either age is more than 40 or the patient doesn't have gross complete resection, the option is RT followed by PCV. PCV, as you could see, if you give it, if it is given in skilled hands in a high volume centers, most of the patients can still complete. Agreed, it has toxicities, but it does not impact the quality of life of the patients. If you are in a low volume center and and you feel that there would be issues with PCV, at present RT with temozolomide followed by temozolomide can be an option, but it's a I would say it's an untested option and does not have an adequate follow-up data with it to support it. There are multiple things. I would like to acknowledge Dr. Nandini for she's a part of our neuro team, Kumar sir and Dr. Jalali, who are my teachers and mentors, and a lot of junior colleagues. And you will see names of some of your seniors and consultants who have worked very hard in neuro to establish neuromedical oncology. A lot of coordinators who have worked very hard with this. And with that, I'm done, and I'm open for any questions if you want to ask. So there are none in the chat box. If anyone has a question, I'll answer, or we can move ahead with the resident. PCV, how do you choose 50% astro received PCV? Is PCV preferred over temozolomide in oligodendroglioma? So if you look at the data, Lingraj, ours is a molecular stratification. So we don't look at the histopathology. We are very clear that when we stratify whether it's IDH mutated or not mutated, and the second thing which we see is whether 1p19 deleted or not deleted. So and it's done by minimization design. So we don't give preference, but the thing is because the DMG wanted it to be 1:2 randomization, that is 2 going to temozolomide and 1 going to PCV. So that is the way the randomization is happening. But there is no preference given to any of the regimen in the study per se. In clinical practice, if you say that there is oligodendroglioma, would I prefer PCV over temozolomide? Yes, I would prefer PCV over temozolomide because I showed you the benefit of PCV in oligodendroglioma over RT is much, much huge. So yes, in the oligodendroglioma, I would prefer PCV over temozolomide in current practice.
Sir, Ligraj here.
Yeah.
Sir, in our data that you have shown that baseline characteristics where the patients who received PCV 50% were astro.
Okay.
So what are those patients we give?
So I'll tell you,
astro?
our study is more of a pragmatic. When we planned this study, we initially thought of doing it only in grade 2 gliomas. But grade 2 glioma is very, very rare. So I'll give you an example. URTC to recruit grade 2 glioma, 18 patients across all of the Europe took around 8 years. So a suggestion was made in the DMG that we want to answer the question of PCV versus temozolomide, and that time Catlin data had come that temozolomide was compared against RT, and in Catlin it did show that it had RT temozolomide had benefit over RT alone. So we take both grade 2 and grade 3 patients in our study. So both are included. So in our study, grade 3, if it is grade 3, it gets included. And if it's grade 2 high risk, then it gets included. So what you're suggesting is correct, because there is a grade 3 component also. A lot of astrocytoma also will get into the study. Lingaraj, I hope that answers your question.
Yes. Okay. Thank you, sir.